my topic for today, which Dr. Sarina has given me, is how do we ripen these grapes, the green grapes that are here. So here is the topic, optimizing success in PCOS. So PCOS is the most common endocrine disorder in women, and a prevalence of 5 to 15 is seen. Currently, the diagnosis is still mainly the Rotterdam criteria of 2003, although Androgen Excess Society, etc., have their own criteria. And PCOS is one of the major causes of anovulatory infertility in approximately 70% of the couples. PCOS is a perplexing condition. One needs all your wits around you when dealing with these patients. How to diagnose, proceed, and counsel in different age groups. How is the adolescent PCOS diagnosed? How in adult with infertility and in older women? So we have to think about all these points, and we have to do a minimum amount of investigation to get an answer. And we have to motivate for the patient to cooperate with the treatment, because it can be a prolonged treatment, and she has to not fall back on cooperating with us. The complexity of the treatment, deciding what to do and when. Some proven methods, some may be experimental, but still you may use it. And how do we counsel to finally achieve a success? So how does insulin resistance cause PCOS? Now it's a vicious cycle of androgen excess. That is what we should understand about PCOS. It favors abdominal and visceral adipose tissue deposition. That then induces insulin resistance and compensatory hyperinsulinemia, and this facilitates androgen secretion by the ovaries and adrenals. So this cyclical interaction between insulin resistance, hyperinsulinemia, and hypoandrogenism is in combination with hypothalamo-pituitary dysfunction results in anovulation and infertility associated with PCOS. And we must not forget that in association with PCOS is a range of endocrine and metabolic traits which we cannot ignore, and we have to address them as we go along. So we have problems of obesity, dyslipidemias which we cannot ignore, insulin resistance, hyperinsulinism, and increased risk of type 2 diabetes and cardiovascular risk. So all this has to be addressed during our treatment. And of course, we may also have an increased risk of miscarriage and pregnancy complications like gestational diabetes. So as we go along, we have to keep all this in mind from an infertile patient who gets pregnant, and thereafter, after pregnancy, we've got to deal with her. So management, of course, is lifestyle changes. We have to explain to her how exercise is important, and this may have to start from adolescence, pharmacotherapy, as well as surgical treatment and assisted reproductive techniques. So all this encompasses the management of PCOS. Now, I must spend a little time on lifestyle changes, which is the first line of treatment for all these patients, promoting weight loss. And a healthy diet and regular physical activity must be advised. This helps to reduce insulin resistance and hyperandrogenism and optimizes the hormonal imbalance, lipid profile, and cardiovascular health. So it's important, and even a loss of 5%, that means for an 80 kg woman or a 100 kg woman, 4 to 5 kg weight loss actually can make a difference to improve the response to your ovulation induction and fertility medication. So the weight loss program is important with an energy deficit of 30%, that is 500 to 750 kilocalories per day, and a general recommendation of 150 minutes per week. That means hardly about 30 to 35 minutes of walking, of moderate intensity exercise, and muscle strengthening exercises on 2 non-consecutive days of a week. Now, if she has modest weight loss requirement, then it has to increase to 250 minutes a week of moderate intensity, plus muscle strengthening activities on 2 non-consecutive days in the week. The effectiveness improves for all this if, of course, she is under a good counselor, a dietitian, and somebody who will take her up her weight loss, and therefore there must be goal setting, self-monitoring, and cognitive restructuring so that she can understand what to do, and problem solving when she faces issues. And finally, a relapse prevention strategy. She may lose weight, and then again when a problem comes, she starts to gain weight. Now, ovulation induction, as we know, is the cornerstone of treatment. And SERMs, we know, have been used by all of us for many, many years. Clomiphene citrate, I'm not going to take too much time on that, but it has to be after establishing tubal patency. It acts as an anti-estrogen blocking receptors in the hypothalamus, causing increase in GnRH and increasing FSH. That induces ovulation in 70 to 80%, but pregnancy only in 30 to 40%. We know we have to do ultrasound monitoring, and we can increase the dose slowly. If this doesn't work, then we document it as clomiphene resistance, and the risk factors for this are obesity, insulin resistance, and hyperandrogenemia. Now, in clomiphene resistance, one can try in combination with metformin. This was suggested by a recent Cochrane review by Morley et al. It had improved clinical pregnancy rate and ovulation rate despite there being no improvement in live birth rates. This is what was said in the Cochrane review. Of course, the next agent is letrozole, most used selective non-steroidal third generation aromatase inhibitor. Now, aromatase converts androgens to estrogen, and letrozole suppresses the ovarian estriol secretion by inhibition of the aromatase. So here, aromatase will act and reduce the conversion of androgens to estrogen, and this causes an increased small amount of androgens increase in the ovary and estrogens decrease. Now, because of release from the negative feedback on the hypothalamus, there is a temporary increase and the temporary increase of the androgens in the ovary. This is what happens. So there is a negative feedback is lost, GnRH increases, FSH increases, and that causes ovarian follicular growth. And the slight temporary increase of the intra-ovarian androgens actually increase the follicular sensitivity to FSH. So all this works, and that is why we get improved ovulatory rates with letrozole. And it has a relatively short half-life as compared to clomiphene, so less adverse effect. And it was first described by Mitwally and Casper in 2001 for clomiphene resistance. And a recent Cochrane review said it has a higher live birth rate with letrozole as compared to clomiphene citrate, and similar incidence of OHSS, no difference in miscarriage or multiple pregnancy, although some studies did say it had less multiple pregnancy because there was more monofollicular development with letrozole. So we know the dosage of letrozole, which we have been using, and it's monitored by ultrasound tracking. Lead follicle reaches 18 mm and a trigger with HCG is given, and followed by timed intercourse. Ovulation is expected to happen 36 to 48 hours later, but if there are more than 2 mature follicles, one should advise to avoid unprotected intercourse. If ovulation has occurred, then if not occurred, then double the dosage. But we must remember, while we are doing this and a lot of us are using it freely, that FDA has not approved it for infertility, but evidence-based guidelines propose its use as a first-line therapy. And it's so widely used now, we have the safety is sort of established. Now, gonadotrophins, going on to the next level. In anovulatory PCOS, this becomes a second option. And in PCOS, gonadotrophins are associated, remember, with a higher risk of OHSS, multiple pregnancy, and so it must be used by experienced clinicians who have to diagnose multiple pregnancies and OHSS in a timely fashion and intervene. Exogenous FSH promotes proliferation of granular cell and follicular growth, and the goal, however, is to promote a single follicle. Whether it is FSH or HMG, it is equally effective with live birth rate, clinical pregnancy rate, and multiple pregnancy rate, and miscarriage rate. Or if you look even at the OHSS rates, it's about the same whether it is FSH or HMG. Nothing to choose from. So basic idea is to prevent hyperstimulation and minimize multifollicular development. So we have 2 protocols, the low-dose step-up protocol or the step-down protocols. In the step-up protocol, lower doses at 75 or 37.5 international units are started, and small increments 25 to 37 after 7 days or more if no follicle has reached more than 10 mm. Ultrasound monitoring for the first 4 to 5, after the first 4 to 5 days it starts, and then every 1 to 3 days it is repeated. Usually it takes about 7 to 12 days for a good follicle to develop, but sometimes it may be longer. In a step-down protocol, high initial doses which are then half during follicular recruitment and growth, this is to mimic the physiological changes. And to reduce multiple pregnancy rate, careful follow-up with ultrasound is required. When one follicle has matured, then HCG is administered and IUI or timed intercourse. If more than 2 follicles of more than 16 mm or more than 3 intermediate size follicles, cycle cancellation is better, or you can convert to IVF. And for this, you should have counseled the patient regarding this, because the cost then changes a lot. Is metformin useful? An insulin sensitizer, which increases glucose uptake from the periphery and increases insulin sensitivity in the liver. Also inhibits gluconeogenesis. So it lowers blood glucose without causing hypoglycemia. It also directly acts on the ovary, where metformin lowers androgen production by the theca cells, and ovarian hyperandrogenism, we have to remember, is responsible for the premature follicle atresia which happens. So theoretically, metformin can have a stimulatory effect on the ovary. Can it be used alone? The new international guidelines suggest that metformin may be used alone, but after informing the patient that we have better methods of ovulation induction, but otherwise you could use it alone. But it has more evidence as supportive treatment in combination with clomiphene or gonadotrophins, or as an adjunct in IVF. Now, the third line is to go on to IVF ICSI, and this may be considered in the presence of other infertility factors, or if your oral medication has not worked and your injectable also has not worked. Now, similar chances for pregnancy or live birth rate per started IVF cycle occurs in women whether they have PCS or they are non-PCS. The problem occurs is when they have OHSs. So they have a significantly greater risk of developing OHSs because of the excessive response to FSH. So a GnRH antagonist protocol is preferred, and over a agonist protocol, which almost most people have now turned to. And this reduces the duration of stimulation, the total gonadotrophin dose, and the incidence of OHSs. So this has been a turning point in this prevention of OHSs. And to reduce OHSs, GnRH agonist is given as a trigger, better than HCG, but this negatively impacts pregnancy outcomes, we know. And therefore, what has come out is a freeze-all strategy that is employed, that is no ET is performed and all embryos are frozen. A frozen embryo transfer can be done in the subsequent or in later cycles. So this is called the segmentation method in IVF ET, and there is no difference in PCOS patients whether urinary or recombinant FSH are used, and no benefit in adding LH. So this is for prevention of OHSs. It probably does not make any difference, is what is recommendations from the International Evidence-Based Guideline for PCOS management from Fertility Sterility 2018. Also, according to the Cochrane database, clinicians should consider metformin use before and during an ART cycle for women with PCOS to reduce OHSS rates in ART cycles. This is evidence-based conditional recommendation. However, it is low-quality evidence. In vitro maturation is retrieval of immature oocytes from antral follicles, followed by in vitro meiosis maturation under proper culture media additives. Since no HMG is required, OHSS is eliminated and therefore is very useful in PCOS women. And children conceived after IVM are not adversely affected. Success rates seem to be improving but remain lower than traditional IVF. A recent Cochrane review actually found that there is no good quality evidence to support IVM in preference to IVF ICSI. And now with better protocols, OHSS is reducing. Now let's look at surgical management. Laparoscopic ovarian drilling and bariatric surgery is also being suggested. So women who are resistant to pharmacological treatment, this may be an option when there is no other choice. Using 5 perforations on the ovary on each side using monopolar energy. This is suggested that it reduces the androgen producing theca cells. So less androgens, so less conversion to estrogens. And there's a reduced negative feedback to the hypothalamus, which causes increasing FSH and fall in LH levels. Now the advantages are they reduced OHSs when we do the stimulation after ovarian drilling, and the multiple pregnancy rates are also reduced, and reduced cancellation rates at IVF. Concerns of a diminished ovarian reserve and periadnexal adhesions are one thing that we have to keep in mind, especially if you roast the ovary like this. So it's not a very favored method, especially you have to think about lowering of AMH and FSH increase. So some recommend just unilateral drilling with similar success rates. Now the poor outcome predictors are who have had long-term infertility, that means they have some other factors as well, or who have marked hyperandrogenism, very high AMH, and also if their LH is low, it doesn't seem to work very well. Inositols, which is being promoted a lot, although some studies did show improvements, 2 recent Cochrane reviews by Shoal et al. And Morley et al. Found no good quality evidence to support inositols. The international guidelines also recommend that inositol should be considered as experimental in PCOS, and if you're using it, present some studies so that we can take home message from that can be taken. So to conclude, PCOS is a complex reproductive, metabolic, and psychological disorder with a variety of manifestations and a major cause of infertility. So as we said, first line should be lifestyle changes, which we should promote and encourage the patient to keep to it, and ovulation induction using letrozole and CC. Gonadotrophins are the next line, and if this fails, one goes on to ART or laparoscopic ovarian drilling. In patients with insulin resistance or hyperinsulinemia, metformin along with clomiphene citrate or gonadotrophins are useful. And at the moment, bariatric surgery, inositol, vitamin D, etc. are considered as experimental. And so we will hopefully learn to ripen the follicles, ideally a single follicle at a time, or one has to go into IVF. And let's hope we end up with ripened follicles like this. I would like to thank you all for a patient listening and the TOGSICON team for a wonderful conference.